We have with us Padma Shri B.C. Roy awardee of Professor Dr. Mahesh Verma, sir. And sir was a past president of ICD Section 6. Currently, he is the chairman of CDE, ICD Section 6, Vice Chancellor of Guru Gobind Singh Indraprasth University, former director and principal of Maulana Azad Institute of Dental Sciences. And I wholeheartedly welcome him. We have also with us our chief guest, who is a very dynamic personality, Professor Dr. Balvinder Singh Thakkar. Sir is also the president of Indian Orthodontic Society and a managing director at Jaipur Dental Hospital. And he has been covered by famous Forbes Business magazine for providing the dental tourism. Honored by Times of India, Dainik Bhaskar, and other organizations as the best orthodontist in the state of Rajasthan. We also have with us the highly eminent personality, Professor Dr. Swatantra Agrawal, sir. He's presently the president of ICD Section 6. Sir is also the principal and professor and head department of prosthodontics at Kotiwal Dental College and Research Center. He's also a member of DCI and has many laurels to his credit. We have also with us Secretary of ICD Section 6, Dr. Y.K. Virmani, and he has also served as a member DCI. He has won IDEA's Best All India State Secretary Award for Organizing Capabilities. We have amongst us Professor Dr. Rajiv Lal as a guest of honor, and he is currently the President-elect of ICD Section 6 of India, Sri Lanka, and Nepal section. We also have with us Professor Dr. V.S. Kohli, sir. Sir is a Deputy Region Central Zone ICD Section 6, Vice President-elect ICD Section 6, and is a well-known orthodontist and a former professor and head Department of Orthodontics at Hitkarani Dental College, Jabalpur. We have with us Dr. Anmol Bagaria, who is the founder and CEO of Cynodent International and a founder president of Indian Society of Dentistry, and also Dr. Ashish Chandra, co-editor, co-director of the Cynodent International, vice president, Indian Society of Dentistry. And this webinar is being organized by the ICD Central Zone Section 6 in collaboration with the Cynodent International and ISD. So we'd like to invite Professor Dr. D.N. Kapoor, sir, to kindly introduce our speaker for the day. D.N. Kapoor, sir. We have Dr. Priyank Rai as a speaker for the day. Dr. D.N. Kapoor, sir.
Am I audible?
Yes, sir, you are audible.
Okay. Sir. I welcome Dr. Priyank Rai, who is Senior Professor in the Department of Postgraduate Orthodontic Department of Maulana Azad. He is a senior grade professor. He did his BDS and MDS from Lucknow King George's Medical College, where I had a chance to assess him, and that's the reason I have picked him up to speak today. And he is BDS from KGMC, MDS, and he is also a recipient of the ICD award as the best orthodontist of the King George's Medical College in 1998. He did his diploma in hospital and health management from IGNOU. He is a member of the Indian Orthodontic Society. He is a member of the IDA. He is a fellow of the International College of Dentists. He is a fellow of the World Federation of Orthodontics and Peripheral Academy. He has been speaking at the international forum, and he did spoke and lectured in the International Organization of Orthodontics at Sydney, Australia, then International Organization at the London, UK. He had been speaking and lecturing in the Indian American Orthodontic Society. He delivered lecture at the 112th AO session at the Hawaii, and then in Philadelphia. Then he spoke and he lectured in Washington, D.C. Then he spoke and lectured in Los Angeles. He was invited by different conferences in India also to give lecture. I welcome him and I hand over mic to him to speak on his topic today. Kindly, Dr. Priyank, please start your. Dr. Priyank Rai.
Sir, is my screen visible?
Yes.
Yes, sir.
Thank you, sir, for those kind words on this occasion, auspicious occasion of Republic Day. My greetings to all. At the onset, I would like to express my gratitude to ICD, and especially to Professor D.N. Kapoor, sir, a past president and currently Central Zone Regent, for giving me this opportunity to share my experiences with skeletal anchorage system. Now we at our center, that is Maulana Azad Institute of Dental Sciences, are working with skeletal anchorage system in all three planes of space, be it anterior-posterior, vertical, or transverse. So when we talk about anterior-posterior, we are doing a lot of skeletally anchored fixed functional appliances, especially in late adolescence, where we're using bone plate in maxilla and mandible, and then we are placing a forceps appliance or a fixed functional appliance, and thereby bringing the mandible forward. Now, the beauty of this protocol is that in late adolescence, when the growth is very little, and you don't want to wait for a full dimension wire to occur for a conventional fixed functional appliance, you can quickly set up this appliance and utilize the residual growth. As also in cases where IMPA is increased, this is a very useful protocol. See, this is not a modality for all cases, but a very useful arrow in the quiver of an orthodontist. At our center, we have been using class 2 elastic with bone plate also. We use a lot of buccal shelf implant for mandibular arch distalization. See, these borderline kind of cases, which otherwise would have gone for surgery under the knife. Now, with this kind of a protocol, like we place buccal shelf mini screws here and when distalize the arch. So you can see a good amount of overjet has been established and now settling is taking place. So we use a lot of buccal shelf implant also for mandibular arch distalization. Now we are using skeletal anchorage on lateral nasal wall also for maxillary protraction. So those borderline cases, we use these mini plates in the lateral nasal wall in growing age patients, especially those whose low upper incisors are proclined. Now, since the upper incisors are already proclined, this kind of a modality is very useful because we have more of horizontal vector with this. And by placing these mini plates, we are more close to the site of the problem. So you can see this case. There is good amount of negative overjet up to 2 millimeter. Mini plate has been placed in the lateral nasal wall, petit face mask, and some decent result. We are also using maxillary protraction, similar kind of a modality for cleft cases. The difference is instead of using it in the lateral nasal wall, we are using the zygomatic buttress because in cleft patients, the problem is the anterior maxilla is quite deformed and destroyed because of the clefting. Now, also in the anterior posterior plane, we are using a lot of intraoral skeletally anchored maxillary protraction for non-compliant patients. That is, we are using either a single jaw or both the jaws. In the lower jaw, we are placing bone plates between the lateral incisor and canine. And in the upper the traction is from the dentition. And you can see good, decent results can be obtained by this protocol. Now, this protocol can be used for bijaw also. In those cases where your maxillary incisors are proclined and you don't want to take anchorage from the upper arch, then we are using bone plates in both upper and lower and class 3 elastics. So if the incisors, upper incisors are proclined, then bijaw can be utilized. Now, when we talk about transverse plane, we are using a lot of MARPE, mini screw assisted rapid palatal expansion, especially in those cases where there is transverse deficiency, the J to J value is less on PSF, as also you've got a lot of buccal corridor space. Now coming to the topic of today's presentation, that is the vertical plane. See, one of the most challenging and deforming malocclusions faced by the orthodontists are in the vertical plane. Whether it is deep bite or it is open bite, they can be both skeletal and dental. When you look at the facial harmony guidelines, artists have derived the divine proportions, also called as the golden proportions, which can be seen in the famous painting of Mona Lisa by Leonardo da Vinci, which follows the golden proportion. We are familiar with the law of equal tripartite, where A, B, and C, all these segments are in good proportion. We are also familiar with law of 1:2, that is the upper lip is 1/3 of the lower anterior facial height. So like in any other case, a proper diagnosis is important also for the vertical problem. You have to identify the disproportional relationships. You have to identify which aspect of the face is disproportionate, and accordingly, you will have to plan your treatment. So important considerations are, what is the growth status of the patient? Is the patient growing or the growth is over? What is the growth pattern? Is the pattern vertical? And if it is vertical, can we use eruptive mechanics? Because we know when we use eruptive mechanics, it encroaches on the freeway space. And when you encroach upon the freeway space, the function is hampered and there is a lot of destruction to the TMJ as also to the periodontium. So you have to be very careful in using eruptive mechanics, especially past the growth. Very important thing is the soft tissue paradigm. We need to know what is the incisor exposure, both static and dynamic. What is the interlabial gap and how is the lip length? Is the lip length short? So in vertical proportions, as far as possible, we try to keep our mechanics in the vertical pattern, vertical growth pattern. We try to keep our mechanics as far intrusive as possible. But we know that intrusion is a very, very sensitive kind of a movement where there is neurovascular bundle, and you have to be very careful. So certain important considerations are, there has to be adequate space available. You need to identify the root surface area. How much is the root surface area? Based on that only we can titrate the amount of force that can be given. We need to identify whether at the onset there are any precipitating factors which can cause root resorption, shape or history of trauma, as also retention and relapse factors. With this much of introduction, I will share my experiences with mini screws and mini plates at our center. The first case that I want to show is a growth modification case with incisor intrusion. So this is about a 12-year-old female, increased incisor visibility. You can see a convex profile, retrognathic mandible, incompetent lips, giving positive VTO. Intraorally, class 2 molar relationship and 100% deep bite. Myofunctional therapy was given and post-functional you can appreciate there is improvement in the profile, better development of the face. But see, when we see the intraoral photographs, we see the upper incisors are still proclined and there is a lot of deep bite. This can be confirmed cephalometric also. You can see that the upper incisors are proclined and the bite continues to be deep. So we started with intrusive mechanics in this case. 2 mini screws were placed distal to the lateral incisor on both the sides as per the center resistance of upper incisors. 30 gram of force was given on both the sides and a ligature was tied from anterior to posterior so that there is no flaring of the anterior teeth. Now this is post-intrusion and you can appreciate a proper step here between the incisors and the canine premolar area. A proper step can be seen, which is a testimony of the intrusion. Canine intrusion taking place, T-loop space closure, and this is the post photograph. Decent results. So this is what mini screw can do to the quality of the result. They can improve a quality of result and they can enhance the quality and patient experience. Now my second case is about intrusion of 6 anterior teeth. So this is a 14-year-old male and his complaint was irregular and forwardly placed upper front teeth. When we look at the nature of problem, crowded anteriors, vertical pattern, incompetent lips, protrusive upper and lower lips. Intraorally, we see there is a lot of arch length discrepancy both in the upper and the lower jaw. So we had to plan where and how to place the mini screw. So we decided to place 2 mini screws distal to the canine in an attempt to intrude the 6 anterior teeth. But what we found is there was a lot of bowing of the arch. So we did a course correction and added a third mini screw between the central incisors. And hence we could get a more parallel kind of an intrusion. So this is the case. You can see we have placed 2 tads, 2 mini screws distal to the canines and 1 in the center. And this is post-intrusion. And this is the result finally. Now my next case is a very interesting case of molar intrusion. Now this patient came with the complaint of difficulty in chewing of food. When we had a look intraorally, we found that the maxillary first molars had supraerupted bilaterally because the mandibular first molars on both the sides were grossly decayed, only root stumps were remaining. So this is very clear and very evident in the OPG, root stumps in the lower and the upper maxillary first molars bilaterally have supraerupted. They have drifted. So on the drawing board, what options did we have? First was either we reduce the maxillary first molar, do an intentional RCT, and then rehabilitate both the upper and the lower. And the second option was to intrude the maxillary first molar and give a prosthetic implant in the lower jaw. Now, seeing the young age of the patient, a tender patient, it was decided that we will go with the second protocol, that is the intrusion of the maxillary first molar and prosthetic implant in the mandibular arch. So extraction of root stumps were done, socket preservation was done, demineralized, freeze-dried bone graft placed, and space maintenance was done by a removable partial denture. So this is how it was done. You can see buccally IZCs have been placed, and palatally 2 paramedian implants have been placed. So IZC, palatal paramedian implants, and NiTi coil spring was used, 200-gram intrusive force, and reactivated every 6 weeks. This was the protocol that was followed in this patient. Now, for the benefit of students, I want to emphasize that what was the beauty of this protocol, how we controlled the vector for molar intrusion. See, sometime back, before the skeletal anchorage system, moving the molar was unthinkable because molars were the anchors. Now, how can something move the anchor? But now there is a paradigm shift. We have used IZC buccally and paramedian palatally. So the resultant force is passing through the center of resistance of the molar, and we could get true intrusion. So in 6 months, we could intrude the molar, and you can see sufficient intrusion has happened that we could place prosthetic implants in the lower jaw. And you can see a very satisfied patient, good outcome. This was published in Australian Orthodontic Journal as a case report in 2016. Now, the next case which I want to show is incisor and molar intrusion. Now, another very interesting case. The patient has proclined upper anterior teeth, increased incisor visibility, protrusive upper and lower lips, incompetent lips, and deficient chin button. When we see intraorally, you will see that 1.7 and 2.7 have supraerupted. The 3.8 and 4.8 are mesioangulary impacted. And this tooth is almost destroyed. So it was decided to intrude 1.7 and 2.7 and upright 3.8 and 4.8. So this is the mechanics that was used for anterior intrusion. 2 mini screws placed distal to the lateral incisor. A distalizing force on the canines. See, it is very important to understand that if you want to intrude teeth, space has to be there. So unless we distalize the canine, we will not be able to intrude the incisors and probably end up flaring it. So it's very important to first create. So there is active tieback on the canine to create space. Canine intrusion, lower incisor intrusion happening. And this is the post-intrusion stepped wire. You can see the 6 anterior teeth at a different plane, and premolar onwards, there is a stepped wire. Now came the turn for molar intrusion. So we placed mini plates in the zygomatic buttress. Now, beauty of this was by placing a mini plate, we could use the same mini plate for anterior retraction also and for intrusion of the molar. And both the molars were cross-stabilized. And you can see the treatment progress from absolutely horizontal. It is uprighting. The upper 7s have intruded. Now this is the post-treatment. Comparative. So this is showing how we have uprighted 3.8 and 4.8. We have mesialized 3.8 and 4.8 and intruded the 1.7 and 2.7. So this is only possible through skeletal anchorage system, such complex kinds of movement. Now this is a wake up for anybody who has slept. Now my next case is implant supported burstone intrusion arch. So when we talk about conventional intrusion arches, there are unwanted side effects. Like there is buccal segment extrusion, and we cannot afford that in a vertical pattern. There is change in inclination of anterior and posterior teeth. There is decrease in intermolar width, and all this may attribute to anchorage loss. So this is the representative case, a typical bidentoalveolar protrusion. Treatment plan decided based on the discrepancy was all first premolar extraction with maximum anchorage in the upper and moderate in the lower, and mini screws placed between the second premolar and first molar area. So this is how a mini screw supported burstone intrusion arch looks. Now it is slightly shorter in height. Instead of coming from the auxiliary, it is coming from the mini screw, and the wire has been sectioned. It's kind of a 3-piece wire. So in 4 months, in 5 months, we could get about 4.5 millimeter of incisor intrusion. Now, the beauty of this protocol is, like I have shown, that we can place mini screws in the anterior and intrude. But the beauty of this protocol is it is very cost effective. The same mini screw can be used for intrusion as well as retraction. As also at times when you place mini screw in the anterior area, it can quite irritate the tissues, it can irritate the frenum, and it can be slightly anesthetic. So same mini screw you can see is being used for canine intrusion. It's kind of a cantilever spring. And the same mini screw is being used for incisor retraction. Caser is being used to retract the incisors. IOPA, no apparent root resorption, carefully titrated forces. And this is the post-treatment result. Happy patient. This is the treatment progress. From here to here, the magnified view. You can appreciate the improvement in the axial inclination of teeth between pre and post. When we see the cephalometric findings, upper 1 to NF, almost 4.5 or even 4 millimeter of intrusion we could achieve through this protocol. Superimposition. You can see the changes. Now, another case of implant-supported burstone intrusion arch, similar mechanics. Based on the discrepancy, all forced premolar extraction, maximum anchorage in both the arches. And you can see with mini screw supported intrusion, we could achieve in 4 months 3 millimeter of intrusion. This we got published in 2015 in International Journal of Orthodontics, both these cases. Now with the same implant, retraction is happening, no root resorption, the final result. The progress of treatment. 3 millimeter of intrusion through implant supported burstone intrusion arch, the superimposition. Now my next case is a very interesting case of posterior intrusion, a case of anterior open bite. Now such kind of malocclusions, they have a huge amount of psychosocial impact and the well-being of the patient. Such patients have low self-esteem, low self-perception. It is quite a handicapping kind of a malocclusion, leading to functional disability as also affecting the quality of life. So we as orthodontists should be very sensitive to their needs. Anterior open bite, gummy smile, incompetent lips, vertical pattern. Now this is showing the gravity of problem. Open bite and compensatory tongue thrusting. When we look at the cephalometric parameters, quite a vertical patient, FMA of 37 and upper 6 to NF. is increased. So the treatment objectives was to correct the open bite and intercept the trunk thrusting habit, besides to achieve the normal overjet and overbite and to get a good soft tissue. So the treatment plan to stop the tongue thrusting fixed palatal cribs, to intrude the posterior mini plates in the zygomatic buttress, an anterior open bite appliance, and 300 grams of force to be applied on each side. So this was the treatment plan that was envisaged. Post alignment, mini plates in the zygomatic buttress. Now, for the benefit of postgraduate students, it is very important to understand the structure of an open bite appliance, an anterior open bite appliance. So now this is the anchor. A triangulation is done, that is from the anterior part of the splint to the posterior part of the splint. And when we look at the palate, the transpalatal arch is kept slightly away from the palate. So now this diagram is emphasizing that there are three kinds of intrusive force which are happening here. One from the coil spring, second from the bite blocks, which is beyond the freeway space, and the third is the tongue pressure, because deliberately the transpalatal arch has been kept away from the palate. So now you can see transpalatal arch, cribs given to control the compensatory tongue thrusting, and the triangulation on both the sides. So this is what our endeavor is, to intrude the posterior segment. This is post-intrusion. You can see the resolution of anterior open bite. It's not because of retraction, mind you. The most of the extraction space is still open. And this is the post-treatment. Pre-stage, pre-post. So this is the wonder that skeletal anchorage system can do to a patient. My next case is again an anterior intrusion, but here a surgical procedure has been used as an adjunct. That is the lip lengthening procedure. Increased visibility, vertical excess, maxillary protrusion, retrognathic, mandible, convex profile. You can see the intraoral. And when we look at the lateral head cephalogram, upper 1 to NF is increased and the patient is quite vertical, FMA of 40. So treatment objective was to reduce the incisor visibility and improve the soft tissue drape through lip lengthening. So 2 mini screws have been placed for retraction. And with those same mini screw, 2 cantilever spring, like it's a 3-piece intrusion arch similar to Bhavna Shroff, where the wire has been sectioned. See, the wire has been sectioned distal to canine and intrusive force is being generated. And since 6 teeth are being intruded, there should be no bowing. A midline mini screw has been placed. Now this is post-intrusion. ANS fracture for lip lengthening, improving the soft tissue drape. And this is the original handicapping malocclusion. And this is the improvement that has taken place. Now this is my last and final case, which I want to share with you. A very interesting case of complete arch intrusion. The chief complaint of the patient was increased incisor visibility. You can see the intraoral presentation. When we read the lateral head cephalogram, we find that upper 1 to NF and upper 6 to NF, both are increased. the mandible is retrognathic and the patient is quite vertical. Again, a very handicapping kind of a malocclusion, which otherwise would have gone under the knife. So the treatment objective was to correct the vertical and to camouflage the skeletal, class 2 skeletal pattern, besides establishing other things. Now, this is a very interesting presentation. I want the postgraduate students to look very carefully because there are 3 splints here, one in the anterior segment and 2 in the posterior segment. Both in the anterior and posterior segment, if you look very closely, triangulation has been followed. That means both the ends of the spling have been engaged so that the resultant is in the middle. There is proper distribution of load. On the buccal side, 4 implants have been placed, that is 2 labial and 2 buccal. And here also you will see triangulation has been done. So 4 implants labially and 3 palatally. Similar mechanics, vector controlled mechanics for molar intrusion and anterior intrusion, that is tandem mechanics, palatal mini screws and buccal mini screws. This is post intrusion. This is what we envisaged upon complete artery intrusion and camouflage by auto rotation of the mandible anteriorly. Stage. Space consolidation happening. And this is post-treatment. Comparative. So finally, I would like to conclude my presentation by saying that control of vertical dimension is a very important factor if you want a successful outcome for your patient, especially if the patient is highly vertical. Now, all cases cannot be treated in a similar manner. Here is the importance of diagnosis and treatment planning, because there is between one patient and the other, there is a lot of variation in the facial pattern. But through these cases, what I want to emphasize is that skeletal anchorage systems have really expanded the envelope. It has pushed the boundary. It has pushed the borders. In fact, the skeletal anchorage system and the mini screw is the new fulcrum for a successful outcome. So if you want a successful case, diagnosis and treatment is very important, and your mechanics has to be vector controlled. Thank you, ladies and gentlemen. Thank you for being a patient audience. Thank you.
Thank you so much, Dr. Priyank. It was a treat to listen to your lecture, a wonderful presentation with great cases. Indeed, everyone would have been benefited by your lecture. Very nice. Wonderful. Congratulations.
Thank you, ma'am.
Now we'd like to request our chief guest, Dr. Balwinder Singh Thakkar, to say a few words.
Thank you so much, Preeti madam. It is, am I audible?
Yes, you are.
Yes. Thank you so much. Thank you so much to the organizers. I'm really grateful to Dr. D.N. Kapoor, who have been so instrumental in, hosting these kind of programs. And indeed, it was a great presentation, Dr. Priyank. Dr. Priyank, and I think it's a orthodontic family, which I can see apart from some, the stalwarts of dentistry in the group. So, and I'm also thankful to Dr. Yogesh Virmani, and I'm good to see Dr. Mahesh Sharma, sir, Dr. Surendra Agarwal, sir, and Dr. Rajiv Lal, sir, President-elect of AICD, Dr. V.S. Kohli, sir, and others who have been there, since the program started, and the lecture as of, vertical control, as of an orthodontist standpoint, it's a very tough challenge to treat these kind of cases. But with the help of these mini screws, the skeletal anchorage systems, we've been able to overcome many of the possibilities, which was very well seen by Dr. Priyank's cases. And I would like to congratulate Dr. Priyank for a wonderful presentation, and indeed thankful to the organizing committee for taking me the chief guest for the evening. Thank you so much. Good night.
Thank you so much, sir. I would like to request
Priyank, some questions?
Agrawal, sir,
Yes,
to
sir.
say a few words. Yes. If any questions are there, we can.
I can see in the messages there are some questions people would like to ask you.
Okay. Okay, sir. Hello, sir. Dr. Viren, sir. Sir, if you'd like to answer the questions.
The first question that is, would you like to explain to us which are the bone plates that you're putting? There are three types of bone plates which you're putting. What are you preferring?
See, we are placing a kind of a Y-shaped bone plate, which has 3 screws. It's a kind of a tripodal stabilization.
Yes, I do agree. I know.
So that tripodal stabilization gives a very good control. So when you want a good amount of anchorage, like one case I mentioned where we are using the bone plate for both intrusion of molar and retraction of anterior teeth. So when you want to do multiple things, I think bone plate should be preferable. And in conventional cases like bidentoalveolar protrusion, probably a mini screw between the second premolar and first molar would be sufficient.
In your case number 6, where you have anterior open bite, posterior this, could you explain that case a little more in detail?
See, in anterior open bite case,
where you have done the posterior intrusion.
We have done the posterior intrusion. So there we have done a kind of a triangulation. That means 4 mini screws were placed in the buccal and 3 in the palatal area. The arch was divided into 3 segments and tandem mechanics was used. That is, the force was being put from both buccal and palatal so that the resultant passes through the center of resistance of these teeth. These teeth were made into an anchor by stabilizing them through a splint. And with this, we could intrude the posterior teeth, auto-rotate the mandible, and camouflage the skeletal class 2 pattern.
Correct.
Thank you, Dr. Priyank. That was good. Very nice of you to explain all this in detail. Any other questions? I think there was one more question from the audience. Somebody wanted to ask you one more question. Just let me look into it.
How much time did it take you to operate the mesioangular third molars?
See, very important thing, sir, to upright a horizontal mesioangular third molar to an upright position. The first and foremost requisite is in any orthodontic treatment, you need space. So our endeavor was to intrude the upper 7s, 1/7 and 2/7. And that needed good amount of zygomatic anchors. So that case, first the 7s were intruded and then through a T-loop, gradually, incrementally, the lower 8s were mesialized as well as uprighted. In fact, the 8s took the position of 7s. So a very important clinical tip here is for any orthodontic treatment, first you need to create space and then endeavor to utilize that space.
Correct. Very right.
Dr. Jahid M wants us to ask you some question regarding auto rotation. Dr. Jahid?
Please.
Yeah. Dr. Jahid, I think we can read the message. Dr. Jahid wants to ask that could we get better mandibular auto rotation by intrusion of mandibular molars also?
See, by and large, when we see that what kind of mechanics we are going to use is based on your cephalometric parameters. So in the cephalometric parameters, we found that upper 1 to NF, that is the palatal plane, was pretty okay. But upper 6 to palatal plane was quite disturbed, whereas the lower was pretty okay with respect to the occlusal plane. So there is no clear-cut mechanics. Your mechanics depends upon the diagnosis. Where the problem lies, right at the onset, I had mentioned that you have to identify where the disproportion is. And once the disproportion is identified, accordingly, your treatment plan is decided. And then the beauty lies in executing your plan. That is, plan your work and then work your plan. So there the beauty lies that you identify the problem. Very well, even the lower molars can be intruded, but that depends on the original malocclusion, the need of the case.
There's another question by someone on iPhone to everyone. Anterior mini screw between laterals and canines. Do you insert it horizontally parallel to the occlusal plane or towards apically at 45 degrees to the occlusal plane? One. Second
See,
is, what do you do when this anterior microimplant fails? Reinsert or at different site, or what's your take?
See, by and large, if your case is biomechanically sound, if your case selection is proper, see, a very important aspect of these kind of protocol is case selection. If the limitations are not there, like if you don't have a systemic problem, you are not putting in a very young child, heavy smokers, thin cortical plate. So by and large, your skeletal anchorage system is technique sensitive. So if you are biomechanically sound and your case selection is good, there is very little chance of failure. But if at all there is failure, then there are alternative treatment modalities. If you can't intrude, then probably you will have to look for probably a surgical outcome or conventional and accept some kind of compromise results. The second question or the part of the question is about angulation. So here I would remind these students about the tent stake principle, where with respect to the tent stake, the direction of force has to be always less than 90 degree. So normally in anterior maxilla, the mini screw is placed almost perpendicular to the cortical plate so that the direction is less than 90 degrees.
Good, correct.
In a tent peg situation, it is always less than 90 degrees. It has to be more than 45 degrees. Otherwise, the tent will just fly away.
So that is how it has to be less than 90 degrees. That is how good old principles which we learned at our institute are still, they're very sound and on sound
Okay,
footing.
second part of the question is, what do you do when this anterior microimplant fails?
So then you will
Reinsert
have
a different side, and what's your take?
then you will have to look for alternative mechanics, like between the lateral and the canine it is failing. Then probably you will try distal to canine.
Yes.
And use that kind of mechanics. See, then you will kick in alternative treatment plans. I showed you a spectrum where you can place the mini screw distal to lateral incisor. You can place mini screw distal to canine. And you can use a posterior mini screw between the second premolar and the molar and use them for intrusion. So their alternative treatment plan. If plan A fails, kick in the plan B, the plan C. If everything fails, then pray to God.
There is one more question from my phone. What's your preferred size of anterior MI and what's the thinnest MI you have used in anterior region?
See, the kind of mini screws that I've used in the past is Fab Anchor I've used Infinitas, I've used SK Surgical also, but I don't bank too much on the brand. The second thing is that on an average, a mini screw of the size of 1.2, 1.3 up to 1.5 is good enough to take load of 500 grams. Now 500-gram load is good enough for most dentoalveolar problems. Beyond that, we have mini screws, and my choice is of bracket head. So bracket head gives you a lot of control, a lot of flexibility, and a lot of control of even the leverage also. 3-plane. You can use a rectangular wire in a bracket head.
Do you have any diagrammatic representation of three-piece intrusion arch? The posterior part being embedded with your micro implant?
See, sir, I had shown in that case, it is like Bhavna Shroff's 3-piece intrusion arch, where instead of the auxiliary tube, the intrusion spring is arising from the bracket head of the mini screw, and the endeavor was to intrude 6 anterior teeth. Since bowing should not occur, we had placed a mini screw in the midline also. So it's very similar to the mechanics of Bhavna Shroff, just that instead of coming from an auxiliary tube, it is coming from the bracket head between the second premolar and the first molar.
Thank you, partner. You've done a very good job. Thank you very much.
Very,
Wonderful
sir.
presentation.
I
Excellent
feel
presentation.
so blessed with such stalwarts. So blessed. So thank you so much.
thank you, Priyank. You did very well. Everybody
Thank
is
you.
very happy. You answered all the questions so well that fundamentals are very clear about it.
Thank
Thank
you, sir.
you.
Thank you so much.
He's got strong basics, very strong basics. I'm very
So
proud of you,
all,
Priyank.
so my obeisance to all my gurus. So they have been the beacon light, they have been the searchlight, and I'm so glad I'm following them. Thank you so much for the blessing, sir. So grateful.
God bless you immensely.
God bless, Priyank.
Thank you, sir.
Thank
Thank you so
you.
much.
Thank you so much, sir. Thank you so much, sir. Would
Very
like
good.
I
Request
would like
Mahesh Verma
to
request Dr. Mahesh Verma to sum it up.
yeah. I would
He doesn't-
request Dr. Mahesh Verma, sir, to say a few words.
Mahesh is busy today because of
Yeah.
Republic Day celebrations. He had some occupancy there. So
Yeah, and
uh,
I would
I've al-
also invite Dr.
I've always
Swatanta
admired
Agarwal,
his way of summing
President
it up.
ICD, to say a few words. He's a gentleman. I really would like to hear a few words from you, sir. Dr.
Thank you, Dr.
Swatanta.
Preeti. It was really great. Dr. Priyank Rai has given such a good lecture, and ICD has collaborated with Cynodent in organizing these webinars. Dr. D.N. Kapoor is instrumental, and he has always been, along with you also in the past, so many webinars during COVID times. And now Dr. Anmol Bagaria is also there, and I'm sure ICD will be benefited by the collaboration with ICD and Cynodent. And so many of our dentists, all from the Cynodent side also, and from ICD, they are all benefited by this wonderful presentation by Dr. Priyank Rai. Although I'm a prosthodontist, but I had also been able to understand what you have talked about, skeletal and all that.
Yes.
Thank you. Thank you very much.
Yes, sir. Dr. YK Mirmani, sir, he's the Secretary ICD. We would like few words from you, sir.
Thank you, Dr. Preeti. And definitely, Dr. Priyank, it was a wonderful lecture. And as I said, that being even a general practitioner, though I don't do ortho at all, but it opened my vision. I could understand that there's so many things that can be done at least. So
Yes.
at least I'll now put pressure on my orthodontist. And thank you very much on behalf of the ICD also. And my thanks to all the organizers for the same. Thank you very much.
You have raised the bar, Dr. Priyank.
Thank you. Thank you for appreciating.
Wonderful, wonderful.
If any dignitaries would like to say a few words, I would like to invite them.
Dr. Swatantra.
Dr. Rajiv Lal is there. Dr. Rajiv Lal. Dr. Balwinder, sir.
Dr. Swatantra, please.
I had, it was a wonderful presentation. I'd already appreciated all the presentation by Dr. Priyank Rai and the efforts made by Dr. Preeti, Dr. D.N. Kapoor sir, and Dr. Anmol Bagaria. Of course, Dr. Virendra Kohli sir, and you had worked nicely as an Anchorage, and the good questions you have asked on behalf of the audience, Dr. Priyank Rai. Thank you, Dr. Virendra Kohli.
Dr. Kapoor, sir. Megha,
Yeah.
would you like to add some words?
Nothing now remains but to thank everyone that they all participated and deliberated well on the topic. So I think everybody is beneficiary. That's enough for the
Thank
day.
you so much, sir.
Thank you.
Thank you so much, everyone. Wishing you all once again a very happy Republic Day and a very happy Basant Panchami.
Thank you. Thank you all.
Thank you.
Thank you.
Thank you, Priyank. Thank you once again.
Thank you, sir. Thank you so much for the opportunity. Thank you.
Okay. Good night then. Bye.
Bye-bye. Bye-bye, everybody. Bye-bye. Thank you.